Welcome to the Fighting Dementia podcast, a helpful resource for families facing dementia.
Brilliant, welcome everyone, and really excited to have Ivan here, and I'll let you introduce yourself.
Sure, I'm Ivan, I'm a psychiatrist. I work partly for the NHS, I'm a consultant. I see patients with dementia, patients with brain injury, and then for the other part of my working week, I'm a researcher at Imperial College London, where I run studies looking at dementia.
Brilliant. And can you tell us a bit about your background in dementia and some of your research areas?
Sure. My main interest in dementia is about identifying people who are at risk, and specifically people who are 5-10 years before developing the first symptoms. And this interest arose from data which is very strong that dementia is actually 15 to 20 years in the making. Mm-hmm. So during that period, the process that leads to dementia essentially develops in people who have no symptoms. On the one hand, that is obviously very concerning for people who may be in their 50s or their 60s to know that, they may have the underpinnings of dementia, but at the same time, it's clearly a window of opportunity because the brain is still otherwise healthy. It's just that it's got this process. And so to that end, part of my research is about what's called biomarkers, right? These are laboratory measures of detecting that somebody has the, if you like, the particularly Alzheimer's disease processes ongoing, but also other types of dementia. So I've got large studies looking at blood biomarkers, so tests of dementia in blood. And then on the other hand, I'm also leading a clinical trial where we've taken a diabetes drug, which has been shown to reduce the risk of dementia in people who take it to diabetes, right? And that's above and beyond its effect on diabetes, because even when you compare it to other diabetes drugs within the same people, so the control of the diabetes is to say the people who are on that drug are about to just then lower risk of developing dementia. So obviously very interested from that point of view. And so we're running a large clinical trial where we are giving it to people who don't have dementia, but they have the Alzheimer's disease underpinnings, right? They have the Alzheimer's disease proteins. We can see it in the brain and so on. And so we want to see whether this diabetes drug changes the rate at which they accumulate the problem proteins. And then another piece of work is around asking questions whether we can use digital to change the course of dementia. So specifically, we know that about 40 or 50% of the cases are at least, attributed to preventable risk factors. So that's things you have some control over. And so the question then becomes, can you use digital to, if you like, work out what are the risk factors that drive a certain individual's risk, and then whether you can come up with tailored programs for them to start to modify that risk. Okay, so that's really where I'm coming from.
Can you talk a little bit more about at risk? How do you class at risk? How do you go about identifying people at risk in your research?
So there's certainly factors that have to do with the medical history. Okay, that have to do with sort of diabetes, high blood pressure, high levels of lipids, whether they've had head injury, whether they've had depression. All of these things explain a part of the risk. And so if you combine these things with age, in sort of algorithms, if you like, if you have access to that sort of data, you can pick out the people who, would have higher than what is expected for their age risk of having some form of dementia. And then at the next level, what you can do is look at their genetics or their blood biomarkers of Alzheimer's disease. These things allow you to have a much more precise view of the risk. Okay, because on the one hand, if you know people's genetics, then there is one particular gene where if you've got the risk allele, if you've got one copy, you're about 4 times high risk. If you're on two copies, you're about 10 times higher risk of developing dementia out to the age of 65. So that if you have the genetics information, obviously that gives you additional data. And then finally, with these biomarkers that I spoke about, you can more or less tell whether they people have high levels of Alzheimer's disease proteins in the brain. Now, that is a particularly interesting point at the moment in the field in Alzheimer's disease, because there's a genuine question of whether, if you have these Alzheimer's disease proteins in the brain, does that mean that you have Alzheimer's disease and it's just that you haven't lived long enough for it to show, and so therefore it should be said that essentially you have Alzheimer's disease without the the decompensation, the sort of the failure of the brain. Okay. Or should you say, well, actually this is still an at-risk state, okay, because we know that when we look at the brains of people who have died sort of in their 80s and their 90s, we know that there's a substantial proportion of people that die without dementia, right? But when you look at their brains, they actually have the Alzheimer's disease pathology, and yet you wouldn't have known, right, if you did a clinical assessment for them, right? So there's these two sort of sides that are sort of currently sort of in discussion, let's put it that way, in the nicest possible terms, about which one is right. Is it that essentially you have Alzheimer's disease if you have these proteins, full stop, and it's just a question of time when that will translate into dementia? Or is it that this is another thing that sort of indicates you're in a high risk? Okay. But whether you develop dementia or not is due to some other factors in the brain. Our people on this side talk about resilience factors. So it could be that it's whether you have added inflammation in the brain that actually sort of tips you over the edge, whether you have problems with the way that the brain uses glucose, for example, that tips you over the edge.
What about environmental factors?
Yeah, again, very interesting. And whenever there's a paper on this, you tend to read about it in the Guardian,
Right.
and wherever, because obviously people are very interested about the environment. Certainly, there's data around levels of noise, level of pollution, whether these factors play a role, and there's obviously what we call publication bias for these things, in that people who specifically went out to look at the impacts of noise, or on the impact of sort of nighttime light, or the impact of air pollution, that they find things, okay, because otherwise they wouldn't publish them. So that's what we call publication bias. So we tend to read about the things that have turned out to be positive, right? You don't hear about the analysis where they didn't find that nighttime light was a problem for dementia, and they moved on to something else. Yeah. Okay, but even then, the accumulating data is that these things matter. Okay, question is how much do they matter?
And you talked a little bit about the biomarkers and the different things that have been left out to predict Alzheimer's. So right now, if somebody doesn't have symptoms and you run the whole suite of tests that can be run, how accurate are the predictions at the moment, we'll say? Just putting you on the spots.
Yeah. This is obviously an active part of research at the moment. It sort of largely depends on whether they have a bit of cognitive change, okay, where they're just off where they'd expect it to be, then your prediction is very strong. So they don't have dementia, but their cognition is not right. Then you can say with a high degree of certainty, lucky when they'll convert.
Make sure those biomarkers.
Yeah, exactly. Biomarkers, their medical history, perhaps their genetics. You mush it all together, and you get a fairly accurate description. In the people who are completely cognitively normal, it's a bit more complex. But still, there are these risk scores that have been developed that take into account these sort of factors with a 10-year horizon. It's above chance, let's put it that way. Okay. But it's not that we can determine with absolute degree of certainty on individual risk. It's a developing field, and people are looking at new ways of asking that sort of question.
because clearly one way to do it is to say, well, we know these and these factors associated with dementia risk. We know about diabetes, we know about age, we know about blood pressure and so on. Let's look at how these 6 factors predict. Okay, so that's one way to do it. The other way is using more complex analytical techniques like machine learning and artificial intelligence and all that zeitgeisty stuff. And the advantage there, of course, is that, especially with us living in an electronic healthcare records world where on all of us there's a lot of data that you wouldn't necessarily think is relevant. Okay, but if you put it in a model, suddenly it turns out that that sort of algorithm is able to pick out things that you didn't think that were relevant, but it thinks that it is. And there we're seeing some improvement on the prediction. But yeah, at the moment we're a bit early in detecting an individual's risk. And the other thing, the final thing that I'd like to say to that is that a big criticism of the risk prediction approach to dementia is that exactly if you follow people up long enough on a population level, and on the one hand you put all the people who you found were high risk with all your fancy footwork, and then the vast majority obviously wouldn't be in the high risk category. What you see if you follow people up for 10-15 years is the majority of the dementia cases are not coming up from the high risk group, right? They're coming from the people who you thought were the other ones in the medium, perhaps low risk group. So clearly, we're missing a lot of the variance. Exactly. So yeah, clearly, we know, for example, I don't want to sort of talk down the field. I think we know a lot about what the risk factors for dementia are. I think it's fair to say we know more about the risk factors for dementia than we do, for example, about risk factors of cancer, right? Okay, at large, not specific cancer, but at large. And yet, there's still something to be done about sort of identifying where the bulk of the dementia cases are coming from.
And so if you did identify someone, and let's say it was 20 years before symptoms or 15 years before symptoms, the Lancet talked this year about that 50% of dementias were preventable. So what would you be thinking about, and what would you be doing, and what would you be saying to those people that, maybe it is, okay, you've said, in 15 years you're going to have symptoms of dementia. What would you be saying to that person to do?
Well, I think what we know about the risk factors of dementia are broadly what we know about healthy aging anyway. Okay, so these are things that have to do with the heart, right? So anything that's good for the heart's good for the brain. This is really like a mantra within our field. So you'd be telling them things about controlling their blood pressure, about diabetes, about sort of lipids. You'd be telling them things about their levels of activity, physical activity, social activity, intellectual activity, and also, I guess if they have some very specific problems around depression and mood, you'd give them some advice about that. You give them some advice about diet, and so on. But ultimately, it remains to be proven, right, that approach works. And that is, in fact, what we're currently setting up at Imperial College London. Is we're setting up a dementia prevention clinic, where on the one hand, we take this fancy sort of algorithms that I talked about, we put them in primary care to identify people who in the local areas are at high risk, and then bring those people into a clinic where it's not just telling them some general advice about healthy aging, right? Because we know that doesn't necessarily work to people in their 60s and their 70s who are understandably set in their ways, and in fact, changing behaviour is pretty hard throughout the lifespan. I don't want to single out 60s and 70s actually, but actually doing a prevention program in which we are, staying in touch with these people, we're coming up with a if you like, physical activity schedule for them, a bit like a personal trainer, with a dietitian, with an occupational therapist who looks at what do they do day to day and so on. Just being fully cognizant of the fact that people need help if they're going to be changing their life, sort of their lifestyle just giving them a leaflet wouldn't necessarily work. And so we're planning to run this for 2 years. We don't want it to be just centered on one center. So this research study will have sites in the west of the country, in Exeter, and then we're looking at another site, probably it could be in the north, to see whether there's any regional differences into how this approach works.
Right.
So yeah, but I guess what I'm saying is it needs this sort of studies. It needs to actually find the people. Can you actually identify who really is at risk, and two, sure, if they're at risk, what can you do? What do people actually engage in?
And then how effective is it?
Well, exactly. And then the small business of have you made
Does
a
it
difference?
work?
Yeah.
Well, that sounds fascinating. And so for a centre to work, you need to have connections with the primary care, so the GPs and their patients, and then a centre locally that can do the follow-up and the work with the patients to give them that support.
Exactly. Because ultimately, I work in secondary care, so I work in bigger hospitals and so on, where, uniquely badly sort of placed to do that sort of thing, because we see people when they're unwell, right? Which is usually when things have when you've missed the boat on that particular sort of what's called secondary prevention. So identifying people who are at risk, they have the underpinnings of a disease, and then you intervene. In secondary care, very difficult. But primary care, where they have access to these people's sort of medical records and know what's happened to them over time. This really is who you need to partner up in order to be hoping to make a difference.
And is the theory that spotting it 15 years before symptoms even making these, is the theory that you could be, not preventing, is the theory that you could even prevent the disease, or is it that you would get more quality of life?
I think the very least we should be aiming with these things is delaying the onset of disease, okay, which to me translates into quality of life. But I think more broadly, I don't, if you're anyway sort of on that path, I don't see a reason why we shouldn't be aiming for a prevention, right? We know that it works for other conditions in medicine, where if you identify the process long enough, you have a cancer, for example, and so on. If you catch it before it spreads and you take it out, are you talking about delaying the disease, or are you hoping that actually the treatment is curative? I think that's the way that I like to think about it, is to aim for something that is a real impact, which would be stopping dementia happening in the first place.
It's very exciting.
And so for people who might be watching the podcast and who have maybe family members with dementia, or they've got other risk factors, some of the ones that you mentioned earlier, but don't yet have symptoms of disease but may be concerned about it, what sort of advice would you give them at this point in terms of engaging with research? Is the research they can engage with, or at this point is it really look at preventative factors, that the sort of general health factors you talked about?
Well, I think there's two sides to this. I would certainly advocate people getting in touch and putting their hand up for research, because we know so much now about how to identify risk, and also we have a lot of different research studies where people that are at a higher risk are actually offered things which we think have a reasonable chance of working. And you don't find about these things unless sort of you indicate that you're interested in this type of issue. So what we've come up on that front is that we've created a large brain health volunteer register. It's called Great Minds. And people can find it if they search for it, where they can join. And then we ask them to obviously fill out a bit of information about them, capturing the main risk factors for dementia. But then we ask them to do a genetic test, because we know about this genetic gene sort of variant that we spoke about that mediates your risk of dementia. We ask them to do memory and thinking tests online. And then the newest thing is we've got a large study that allows us to take blood in 27 sites across the country, where we look at dementia risk factors. And then we package all of these things up so that we know exactly what type of study is suitable for that particular person, right? We have clinical trials where, for example, we're looking at a diabetes drug which has been shown to reduce the risk of dementia by about 30% in people who take it for diabetes. So we're asking questions about whether that's useful if it's given to the people who are in the at-risk group as well. We have digital therapeutics, where we're asking questions around, if you create sort of personalized programs using digital, can it sort of change people's risk? And then there's a variety of other things that people can get in touch with. We've got studies looking at people's speech to see whether the speech is can signify risk. We've got sort of we send out devices where we look at whether people's sleep can perhaps associate with risk. So that's, if you like, the volunteer bit. And I would certainly recommend that, because at the moment, through research is how, for example, you get access to the latest tests. Okay, so we've got studies that measure the amyloid in the brain. We've got studies that measure the tau protein in the brain. These are the two main Alzheimer's disease proteins. We have studies that we put people through MRI scanners so we can have a look and see what is their level of the scarring of the vessels in the brain, sort of as a way of assessing their risk of vascular dementia and so on. And these are tests that are not trivial to get, certainly on the NHS, but even more broadly. And therefore, this is information that, if and when it becomes clinically relevant, we can share that with their doctors and so on. So there's a benefit to being part of brain health research at the moment. So that's if you like the volunteer piece, and then about the things that people can do sort of at home, if you like, especially if they don't want to take part in research. We've certainly tried to work on that sort of Lancet Commission paper that you spoke about, that identified that 40 or 50% of dementia cases are due to preventable risk factors. In that, we've created an app that people can download. Sort of, it's on the App Store, it's on Google, it's free. That allows people to quantify their risk of future dementia with a 10-year horizon, and then work out which factors are driving their risk. Then it'll give them a plan of sort of just to work out what it is that they can do, sort of to plan sort of a lifestyle change that will change their lifestyle risk factors, and hopefully by extension their dementia risk.
That's brilliant. What's that app called?
It's called 5 Lives. It's with a company that I work very closely with, and I have an interest in. So it's free. So if people are interested, they can download it.
That's perfect.
It looks nice. Yeah. It looks nice. It's always important to wrap.
It works.
It's got all the colours and
absolutely.
And so on,
Brilliant.
Yeah, that's good. That's really helpful.
It is.
And Great Minds, you mentioned, if people search for that, and we can put the link in.
We'll put the link in the show notes.
Great Minds for dementia. If you Google that, it's one hit. That you'll
Perfect. Get. That's really valuable.
Thank you.
Thanks. We had Dr. Graham Smith, who's got a background in nursing and research, and in episode 2, and he talked a bit about if you live well, then you can live well with dementia. And I wondered what your thoughts were on his perspective on that.
Yeah. I think certainly the perception of dementia has changed, in that I think we have to be quite clear that this is a condition with stigma attached to it, because people usually, when they think of a disease, they imagine the worst case, right? They're not imagining the people who are sort of walking about and you wouldn't know that they have the disease. They imagine the people who are having a pretty rough time. And obviously within dementia, once you get diagnosed, there's a considerable variance, considerable heterogeneity in terms of what happens to people. Some people will become unwell very quickly, and some people will become unwell sort of over a longer period of time and so on. But we need to be quite clear that dementia is a progressive condition, okay? If you've been diagnosed with dementia and in 5 years' time nothing much has changed, your diagnosis was probably wrong. Okay, all right, and that does happen. We know that there are things that present like dementia, that people can get them confused with a dementia. But dementia is ultimately a progressive condition. Within that, as I say, significant sort of variation from person to person how that proceeds, and there is some scope to what people can do to live well with dementia. Again, it goes back to sort of general principles of healthy aging. If you want to have a good time as you age, you'd do well to look at things like, your balance, your how active you are, muscle strength. These are sort of things that you don't necessarily associate. You think of it as sort of things that people do to look well, right, in their sort of early and midlife, but actually they're super important as you age. And of course, there's, if you like, the physical side, and then there's the, if you like, the activity bit, which is, how socially active are you, how physically active are you, sort of in terms of getting out of the house, and then intellectually active. We know that these people, even if they have dementia, they generally sort of don't progress quite as quickly as the other ones.
Yeah, because I think he talked about learning new skills, even if it's not being great at a new skill, but sort of learning new skills can be of benefit to sort of, the intellectual side that you're talking about.
Yeah, exactly. I'd file this under intellectual stimulation.
Yeah.
We know that it helps. And we know that actually a skill, something that has a life, real life, sort of, if you like, sort of function, that benefits us much more compared to learning how to do Sudokus. Okay. All right.
Yeah.
Because what you're trying to do here is keep the brain active. The brain was sort of evolved the way it did over sort of millennia, is because it helped us sort of work out patterns and sort of interact with the environment and so on. It wasn't quite made for Sudokus and collecting dots and so on. It's in there.
I'm not sure everyone would agree with you on that.
Oh well, But if you can learn it, I guess my point is, if you can learn a new instrument, or if you can learn a new language, that's probably going to do your brain.
It's more complex.
More good. Yeah, exactly. It's more what we would call ecologically valid, right? It's closer to what the brain is meant to be doing in the first place.
That makes a lot of sense.
To things that we've devised and think they're cool and they're nice, which they are. But yeah, I think your brain benefits more from things that are a bit more holistic.
So the brain training apps.
Yeah, they're an interesting one. I think the jury's out on that one.
Yep.
And we're working hard on this. Again, with this app that I mentioned, we do have a version of it which is sort of to give to people who have cognitive problems, and to see whether, given that it's on an app, they can do it at home, whether if we give that, for them to engage with at home, whether we're going to see things which we haven't been able to see when we ask them to come in 2 or 3 times a week to the hospital and do tests with us, whether we're going to see some change. But you have to be a bit guarded about that one, right? It certainly does no harm, let's put it that way.
Yeah.
But I think the evidence for this type of therapy, it's called cognitive remediation therapy, is variable. Okay, and we need to understand why it's variable. Clearly some people benefit, but some people don't. So I think it's one of those. If it's something that you enjoy doing, I'd certainly say
Pretty good.
yeah, it's pretty good. It's pretty good. You're probably getting some benefit out of it. Okay, all right. But forcing it to people just because I suspect may not work on it in every case. And actually your time will be better spent sort of going for a brisk walk and socializing, going dancing, where it's still a cognitive exercise, right? In fact, if you're going to do one thing, it's probably, especially at the late life, it's probably pick up dancing, because it hits the intellectual, it keeps it keeps the social, it ticks the social, and also the physical. So
yeah, great.
That's the one thing.
Good tip.
Great tip.
And you touched briefly on diagnostic and the fact that some people might be misdiagnosed early on. I think I'd be interested in the sort of primary care GP setting. Are there more nuanced diagnostic tools starting to filter through? Because I think historically they've been fairly basic diagnostic tools generally.
I would say that the main advance is probably the blood biomarkers. Okay, and so on that front, I think I mentioned this, that we've got this big study funded by Alzheimer's Research UK and Alzheimer's Society and the People's Lottery and the National Institute of Health Research, where we asked that question. We ask whether blood biomarkers are mature enough to have a meaningful difference in the diagnostic flow in the NHS as it stands. So we're going to have over 3,000 people who are, have a cognitive problem, and we're going to see which blood biomarker works best for which type of condition, okay, which type of dementia. And then, in the last 2 years of this particular sort of grant, we're going to run a clinical trial where, half of the people, we're going to give them the results, not just to them and to the clinicians as well, and half of them will be just treatment as usual. And then at that stage, we'll be able to see whether that makes a genuine difference to what happens to their dementia journey. So I think probably that's the most proximal, the most sort of immediate thing that will filter through to primary care specifically. Because I think we have to deal with the realities of primary care, is that, they are sort of working at capacity and have been working at capacity for a while now. So to expect them to do sort of bigger and better things, especially with the same tools, isn't probably realistic. But rather you need some genuine technological advantage, sort of advance to meaningfully shift the dial. And I think blood biomarkers will probably be that sort of difference.
Brilliant. So during the course of the last couple of years, we've learned and read a lot about reminiscence therapy,
Right.
And automated reminiscence therapy and those types of things. What do you think about therapeutic interventions for dementia in terms of the talking side?
Yeah, I think therapeutic interventions in dementia are needed. I think that's certainly a recognition that at the moment a lot of the attention is focused on the field that I'm interested in, which is, can we prevent dementia? And actually, if you look at what happens to people once they've developed the condition, usually, people lose interest because it's a rapid condition, right? With very often not a very favourable diagnosis, being a progressive condition. And so I think there's a substantial need for new treatments in that space. More broadly, I think there's a substantial need to just understand what governs these differences. Why does one person with dementia have one cause, another person has another trajectory? So the one that you mentioned, reminiscence therapy, especially, sort of in its automated version, I think it's a huge interest to me, because on the one hand, I think that it's a space where we need to be doing better. We need to be providing some therapy to these people. Just because they've got dementia doesn't mean that they couldn't live better with it, and we couldn't improve some of the symptoms. So, and reminiscence therapy, from what I understand about it, and I'd welcome you, Leon, to tell me more, because I know that you have an interest. From my understanding of it is that there is some evidence base behind it. And I think because it can be used to directly collect data from patients, it can then be used to improve our understanding of what's happening to people once they have dementia, because they're so often lost to the healthcare system in many ways, simply because they moved, for example, into institutionalized care, into care homes, where it's a completely different system outside the NHS, and you only get glimpses of often when they become very unwell and they come to secondary care, to the hospitals with a problem, and then they get discharged again. So I think potentially it could be a valuable tool both for therapy but also improving our understanding. But anyway, back to you in terms of what you would say about this type of
thing. I mean, well, we spent a lot of time with young onset groups in Liverpool, and the feedback that we get from those people who are both diagnosed and their carers is that it feels like you get diagnosed, and I don't know if your experience was similar, Steve, that you get diagnosed and it's like almost see you later until things get really bad, and that can be years for some people, or it could be a shorter time depending, as you say, on how it progresses. And it seems that doing reminiscence therapy or providing a service that's there for them day in, day out, to look at their life and look at their behaviours isn't really there, and they have care navigators, but they're very stretched people. So it does seem to be falling down to the individual and to the families to sort of manage what happens from that moment of diagnosis, and I think that's where therapeutics, you know, because everyone's so different and present differently and have different like risk factors, or maybe they've got diabetes, maybe they haven't. So there's, from the therapeutic side of talking through, you know, I've just hosted an episode with Fran, who has 2 types of dementia, vascular and Alzheimer's. Right. And she was diagnosed 7 years ago now and is still doing a podcast with me and still visiting her friends every Monday, still spending a lot of time with family, has a real positive approach to what's going on in her life. And she's an inspiration in that sense, but she met an academic 4 years ago who told her about diarising, and so she writes a diary every day of how she felt and what was good and what was bad. And so her approach, she was a nurse, and she fought for a diagnosis very early in seeing some signs that she wasn't quite right. And so like through her experience and like talking to the group, it seems that a therapeutic intervention like early on to really talk about that person, what they can do and who they are, and to talk about their memories and to build that sense of self could be really interesting as something to do for people considering it. And that's why we've created a Leaf Story, and which is really early days in the app, but it's why we're really excited about it, because it can be a very personalised conversations about that person's life.
And I think potentially, hearing you speak now about, you know, the fact that a lot of these people, a lot of the patients with dementia are indeed sort of looked after by their family. It's a family illness, right? You know, it's easy for something like this to alienate the families, right? Both sort of within them, but also to sort of isolate them from the rest of the society, right? Because it's a difficult condition to look after, right? And so I'm thinking that a reminiscence therapy, you know, could have value in terms that it just humanizes the experience again of that person who's living with dementia. And I guess, you know, it could serve a purpose in that it could help reconnect the family to the person, right? Rather than to the illness, right? Because at some point, obviously, you can speak about this more than I can, but I have an outside view. But yeah, at some point, it's just so overwhelming an experience for the families that actually, you know, you are at risk of stopping to seeing the person, right? Plus the fact that they've changed so much through the illness. But yeah, so I think reminiscence therapy may have sort of additional benefits, sort of beyond the family unit. What do you think? What is that?
Yeah, it's interesting what you said. I think we've certainly found that there can be a danger that you end up focused on the practical elements, or focused on the negative side, or focused on the things that are going wrong, and you can lose sight of the person that's still there potentially. I think particularly as people progress further in the disease, and it's harder to find the person that's still in there, but we've certainly found in recent months just taking time to do that and just pause and spend a bit of time appreciating the person has been really helpful, because then it changes your perspective from the family side as well. So yeah, things like reminiscence therapy, I think are a good step in that direction. You know, even without any, like, even setting aside any potential therapeutic benefits, I think they can, as you said, they can be beneficial from a companionship and family perspective, which then in turn, the conversational benefits, like the cognitive benefits of conversation and of interaction are pretty well established, aren't they? So that naturally is going to have a...
And I think it's super important to keep the families sort of engaged, because we know that the people who do well with dementia, the people who stay in their own homes and stay within their familiar environment and so on. And we know that it's a very difficult thing to sustain over time for the families. And so if there was a tool that, if you like, keeps the bond alive in a way, you know, there could be sort of direct benefits back to the person living with dementia, in that they'll stay within the family structure for longer and benefit from that.
Yeah. Yeah, and it's interesting, just as I was listening to Leon talk as well, I think once there's a diagnosis, often, and probably as individuals and family members, you're looking for something like a medical intervention that will, like some sort of drug that will stop the disease, or, and that I think often from the point of diagnosis, that tends to be the focus, is get a prescription, take the medication. But there's probably less than therapeutic intervention, like softer therapeutic interventions beyond that. So.
Yeah, and we know that they work, right? We know that that's really, what makes the difference. But very often they're not what we say scalable, right? Because they're dependent on very, skilled therapists, and there's only so much that they can do, inevitably, in an aging society, dementia will grow in importance and in need on a population level over the next decades, and you can only see this sort of capacity shrinking rather than increasing. And so if there was anything that made a difference but that could be scaled, you can see the obvious advantage.
Great. And what advice would you give to someone early in their diagnosis? Say, like, they've just been diagnosed. What would you be giving them in terms of advice with what you've learned about dementia?
Again, the advices would be around what we know are healthy aging advice.
Yeah.
Start dancing.
Start dancing, definitely.
Yeah.
Definitely. There's nothing, very often, people are, reluctant to try new things because we're just reluctant to try new things, not because we have a disease of some sort. But in this case, it will make a genuine difference. So that's what I would tell them, is that now is the time to try these new things if you can do it, if you can manage it. But more broadly, look after your heart. Anything that's good for the heart, it likely will benefit your dementia. Stay active in all sense of the words, right? Don't retreat. Some people get very downcast by the fact that they've been diagnosed, and that feeds into sort of, it's a vicious cycle, right? Where the more you retreat, the less you're able to then to regain as and when you're ready to come out.
Absolutely.
But these would be my broad.
Yeah, we've got one gentleman who's in the young onset group, and he's, I think, 2 or 3 years into diagnosis, and he still works in a pub as a cleaner every morning, 9:30 till 12:30, and it gives him a really great sense of purpose and a really great sense of belonging in, in society, but obviously with the people that he interacts with in the thing. And I can see that when I've chatted to him, it's like really important to him to keep that going. And obviously the pub is being supportive, because I'm sure he's changed in that time, but he's still, really excited to turn up and do his job.
Yeah, definitely. Structured activities, making sure that you've got things locked in during the day that you just have to go, right? It's not a choice, right? You have to be there. Situations where you have to interact with other people, again, not a choice. Because, again, on a very basic level, again, we go back to what the brain is meant to be doing. The reason why, we've got it so well developed is that we are a very social species, right? And so there's a lot that goes on, even a very simple conversation with somebody, right? Your brain is actually working very hard in reading what's going on in the room, and therefore it's really sort of thinking about it in simple terms. It's really giving your brain a very healthy sort of exercise, because you're asking it to do what it's meant to be doing.
It's a really good, simple way to think about that, actually. Great. I think you've covered a lot of the end questions.
I do talk a lot.
No,
I apologise.
It's
I think
been really
maybe just one last question. We talked about a lot of things that are going on in the research and developments in the space. What's maybe one or two things that are most exciting for you as you think about either things that we've just found out about, or things that you can see coming in the next 2 to 5 years, maybe?
Well, certainly the big developments have been sort of the new therapies that have been approved, that I'm sure you know about, that clear off the amyloid. Obviously very controversial, because, they're, on the one side they're toxic, on the other side, but also, they're the first ones that show that if you remove these proteins, there is some impact on cognition and on level of functioning, which is sort of your acid test. So they're certainly very exciting. but at the same.
That's medication.
That's a sort of an antibody, right? So, you know, the regulator in the UK approved them, right? As a doctor, I can prescribe them, but as a consultant in the NHS, I cannot give them to my patients because the NICE body, which is looking at whether it's good value for money, found that it wasn't, right? And you can see where they were coming from, right? Because it's relatively modest benefit for a big cost, okay? But ultimately, the reason why I think is exciting is twofold. One is that we know that at least in the cases of carefully selected people with Alzheimer's disease, we now have some way of changing the underlying process, right? That actually makes a difference in terms of cognition, because that wasn't certain at all. So that's, if you like, one. And then the other one is that it really is sort of forcing the whole field to be thinking about, okay, I've got this dementia person in front of me, but what is it caused by, right? It's forcing people to think in terms of, is it Alzheimer's disease pathology? Is it vascular? Is it Lewy body? You know, where previously it would have been largely sort of academic, right?
Yeah,
Getting it right as a clinician, you know, as a sort of, there's a pride to it, but actually it doesn't really make a huge deal of difference. On the management side here, you know, because we've got these new therapies, you'd only be able to prescribe them if and when they become available on the NHS, if you know that it's Alzheimer's disease, right? You've done the test, you've done the biomarkers, you've done everything, and you know, yes, this is a dementia caused by Alzheimer's disease. It's a different way of thinking, right? So that's what probably is certainly, you know, is causing a lot of ripples in the profession for obvious reasons. But I guess what I'm sort of excited about is thinking about, you know, the approach that I spoke about earlier, which is identifying people sort of earlier in the disease and asking the question, well, are there medications that are already prescribed to people for other conditions that can actually make a difference in that particular scenario? And that's certainly what we're working with. You know, I think I mentioned that we're running a clinical trial where we identify people who are at risk. So they have amyloid in the brain, they don't have dementia, and then we're giving them this diabetes medication, which has been found to reduce the risk for dementia in people who take it for diabetes by 30%. And therefore, I'm really quite excited about that particular direction, is that there may be drugs. It doesn't have to be this one, it could be other ones. There's a number of medications that have been put forward, which are, you know, very often what's called off-patent, right? So they are very cheap. We know a lot about them in terms of their safety, but you know, because we now have so much data on people who take them for other reasons, we can work out if there's a signal, if there's an indication that it changes the risk of dementia. So I'm quite excited about the potential of those.
Great.
And in terms of keeping up with all of that, you know, if you're someone who's really interested in this, would you say it would be the brain, what was it called?
Great Minds.
Great Minds, sorry, yeah. Would you say it's the Great Mind, like registering with Ed? Is there a newsletter or?
Yeah, well, definitely. I think it's, you know, I've created this, so I'm one of its main advocates. I would certainly recommend it because, you know, we do have a newsletter. We also organise these events that are happening every 6 months where we bring, you know, the biggest experts in dementia and brain health, research-wise, to give talks to a lay audience. Okay, and then these events are, you know, there's 2 talks that cover specific topics. So each event will have a particular focus, be it, you know, vascular dementia or Alzheimer's disease, or the next one that we're having in May is looking at the latest advances in diagnostics. You know, 2 not too onerous talks, about 25 minutes and so on, and then a Q&A section where, you know, people who stream it online can ask us questions. So if that's of interest, then I would certainly recommend that. But we're not the only ones doing those.
No, it's a great resource. Thanks.
You know, I think if people are interested, then there's other things that are happening. So stay active.
Great. Thanks for your time, Ethan. I think it was
pleasure.
really insightful.
Yeah, super
to get your perspective, and good luck with all the research.
Thank you very much. Well, thank you for having me.
Thank you.
All right. All the best. Bye-bye.
Cheers.